Bismillahirrahmanirrahim. Today topic is the lower urinary tract infections. These kind of infections, they are very important to sector because you see in OPD, you see in wards, ICUs in various places, and this is the most common pathology in urology हो सकते हैं. So proper diagnosis, take a proper history along with proper diagnosis, and then proper treatment with proper dosage along with the duration is more important as compared to you simply write it down Ceproxin for 2 days or 3 days or whatever that's with incorrect dosage along with incorrect durations, because these infections are not eradicated हो सकते हैं, so they land up or patients land up into recurrent UTIs, resistant UTIs हो सकते हैं, so or complicated UTIs. So with proper diagnosis and proper antibiotic हो सकते हैं for the betterment of the patient. चलो start करो यार. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Yasaman. I am the resident of urology. Today's my topic is lower urinary tract infection. The content of my topic is urethritis, prostatitis, cystitis, bladder pain syndrome, and last one is the chronic pelvic pain syndrome. First of all, we discuss about the urethritis. It is the inflammation of urethra, which is multifactorial condition and characterized by the dysuria with or without urethral discharge or may be asymptomatic. The causes, it may cause infectious causes and the non-infectious causes. The infectious causes further divided into the gonococcal and the non-gonococcal. The gonococcal may cause the Neisseria gonorrhea 50 to 90%, and non-gonococcal chlamydia trachomatis, urea plasma laticum, mycoplasma genitalium, trichomonas vaginalis, yeast, or the herpes simplex virus. The non-infectious causes are trauma, urethral stricture, catheterization, and the chemical irritant may cause urethritis. There are two types of urethritis: the gonococcal urethritis and the non-gonococcal urethritis. In the gonococcal urethritis, the Neisseria gonorrhea is the relatively common cause of urethritis, and it is present in the predominant intracellular polymorphonuclear leukocyte and may affect the columnar epithelium of urethra. The clinical pictures affect the urethra affect both sexes and transmitted by the sexual contact disease, and the incubation period is 2 to 5 days. The symptoms in the male: discharge, profuse, purulent or yellowish green, intense burning sensation, fever or malaise. 50% males are mild or asymptomatic. The site of in male, it is the anterior urethra is more common. And in female, discharge scanty or mucopurulent, cervical discharge, vaginal pruritus, dysuria. Mostly 50% females are asymptomatic, infected asymptomatic, and the primary site in the female is endocervical canal. Complication, if not treated with urethritis, then may cause in the male posterior urethritis, epidermitis, acute or chronic prostatitis. If untreated, then the periurethral abscess. In the female, it may cause pelvic inflammatory disease, pubo-ovarian abscess, subsequently ectopic pregnancy, chronic pelvic pain, infertility, and the Fitz-Hugh-Curtis syndrome. It is the syndrome in which the inflammation of the liver capsule associated with the urogenital tract infection. The CDC treatment guideline for the gonococcal infectious, uncomplicated infections of gonococcal urethritis, treated with the ceftriaxone 500 mg IM in a single dose. If the ceftriaxone cephalosporin allergy, then the gentamicin 250 IM single dose with azithromycin 2 gram orally single dose. If the ceftazone are not available, then cefixime 800 mg orally in a single dose. Further move on, non-gonococcal urethritis. It is mainly caused by the chlamydia trachomatis. It is a gram-negative intracellular microorganism that preferably infect the squamous-columnar epithelium of the urethra. The clinical features, symptoms same as the gonococcal urethritis, but mild. The incubation period is 1 to 3 weeks. Low-grade urethritis with scantily or moderate mucoid mucopurulent discharge. Female are mostly asymptomatic. Diagnosis criteria. The diagnosis criteria of urethritis can be confirmed by the symptoms in the complaint of male patient and presence of following one of them: the purulent discharge on examination, or 2 white blood cells per oil immersion field from the gram stain of the urethral swab, or positive leukocytes estrase dipstick presence of 10 WBC per high power field of the first white. Non-gonococcal urethritis, treatment of non-gonococcal urethritis is doxycycline 100 mg orally twice a day for 7 days. And alternative is the azithromycin 1 gram a single dose, or azithromycin 500 orally with single dose, and then 250 mg daily for the 4 days. If the persistent recurrent non-gonococcal urethritis, then doxycycline 100 mg orally twice a day for 7 days, followed by the moxifloxacin 400 mg twice a day for 7 days. And the alternative, if the doxycycline 100 mg 200 twice a day for 7 days, followed by azithromycin 1 gram orally, and followed by the azithromycin 500, and then for 3 days, and last after the completion of therapy 21 days, we repeat the culture for other is the persistent or recurrent non-gonococcal urethritis test for the mycoplasma genitalium, then macrolide sensitive and the macrolide resistant. In the macrolide sensitive, the doxycycline 100 mg twice a day for 7 days, followed by azithromycin 1 gram initial dose, and then azithromycin 500 once a day for 3 days. And the macrolide resistance, in which the doxycycline 100 mg, in which we don't not use azithromycin, and the place of azithromycin we use moxifloxacin 400 mg per day and for 7 days. Further, the second is the prostatitis. Prostatitis is an inflammation of the prostate gland that is caused by infectious agent, bacteria, fungi, or the mycoplasma, or other condition including the urethral stricture, prostatic hyperplasia. The National Institute of Health classification divide further 4 types of prostatitis: the acute bacterial type 1, and the type 2 is the chronic bacterial prostatitis, type 3 is chronic prostatitis or chronic pelvic pain syndrome, and other one is asymptomatic inflammatory prostatitis. The pathogenesis of the acute and chronic bacterial prostatitis. Both acute and chronic bacterial prostatitis generally result from organism reaching to the prostate gland by one of the following route: upward ascending from the urethra, downward from descending from bladder, and via bloodstream or the lymphatic channels. The common organisms can cause the acute bacterial prostatitis, mostly E. coli, which is 75 to 85%, and other one is Klebsiella, Pseudomonas, Enterobacter, Proteus, Neisseria gonorrhea, or group D Streptococcus may cause acute bacterial prostatitis. In the chronic bacterial prostatitis, involve the recurrent episode of infection And in the chronic prostatitis or chronic pelvic pain syndrome, it is a newly termed described syndrome with prostate and urinary pain in the absence of any obvious infectious. The etiology is unclear. Fourth type, asymptomatic inflammatory prostatitis is usually diagnosed in individuals who have no symptoms but are found to have the inflammatory process in the prostate. The clinical manifestation of the acute bacterial prostatitis, it may cause a fever, spike, chills, perineal discomfort, dysuria, frequency, urgency, and nocturia, pain with ejaculation, pelvic or perineal pain, prostatitis, and the hematospermia. Evaluation. The acute bacterial prostatitis can be evaluated by the detailed history and the physical examination. And the patient have the complaint of febrile 38.4 centimeter centigrade. The blood culture may send for diagnosis. If the urine analysis and the mid-stream urine to support the diagnosis, and the urine testing before and after the prostatic massage, the patient remain febrile after 36 and the symptoms do not improve with antibiotic, then transrectal ultrasound indication. The complication, it may cause a bacteremia, epididymitis, chronic bacterial prostatitis, prostatic abscess, and the metastatic infection like spinal or the sacroiliac infection. The prostatic abscess. And the incidence of prostatic abscess is currently low with use of appropriate antibiotic therapy. Certain underlying conditions like diabetic, HIV-related immunosuppressive may predispose the development of the prostatic abscess. The signs and symptoms are similar to the bacterial prostatitis, but may persist despite appropriate antibiotic therapy. Diagnosis of the prostatic abscess on physical examination, DRE, this edematous or tender, and transrectal ultrasound, we show a hypoechoic or anechoic area with thick wall or peripheral edema. And the CT scan finding, there is a non-enhancing fluid density collection that can be multi-septate or rim enhancing lesion. And the lab finding, there is the leukocytosis, pyuria, bacteriuria, and the elevated the PSA level. Urine culture typically reveal the positive organisms as acute prostatitis. The treatment of the acute bacterial prostatitis and the chronic bacterial prostatitis. Uncomplicated acute bacterial prostatitis primarily treated by the ciprofloxacin 500 mg per orally twice a day, or levofloxacin 500 to 750 mg once a day, or alternative is trimethoprim sulfamethoxazole double strength 1 tablet twice a day. The duration is 14 days, may extend it to 4 weeks, and adjust ciprofloxacin, levofloxacin, or trimethoprim sulfamethoxazole dosage according to the renal deficiency. And the urine culture may be done 2 weeks or and the 4 weeks after the therapy completed. In the uncomplicated acute bacterial prostatitis with the restrictor of the sexual transmitted disease due to the Neisseria gonorrhea or chlamydia trachomatis. First, we give ceftazone 250 mg IM or the cefixime 400 mg with single dose plus doxycycline 100 mg per orally twice a day for 14 days, or azithromycin with 500 mg once a day for 14 days. In the consideration, the fluoroquinone no longer used for the gonococcal infection, urine test, or if Neisseria gonorrhea or the chlamydotrachomatis. In the complicated acute bacterial prostatitis that caused by bacteremia or the prostatic abscess, in which we advise giving ciprofloxacin 400 mg IV, twice BD or levofloxacin 500 mg once a day. If not present, alternative is the ceftazone 1 to 2 gram once a day plus levofloxacin 500 to 750 mg once a day, or etopiram is 1 gram IV per oral once a day, or the piperacillin tazobactam is 3.375 IV 6 hourly. The duration is 4 weeks. Ultrasound or CT to be confirmed the abscess. Then IV switch can be oral if the blood culture or abscess drain. In the chronic bacterial prostatitis, first we primarily give ciprofloxacin 500 or orally twice a day, and the levofloxacin 500 to 750 mg per orally once a day. If not present, the alternative drugs is doxycycline 100 mg give per orally, or trimethoprim sulfamethoxazine double strand tablet BD use. Duration is 1 to 3 months. Another topic is cystitis. It is the inflammation of the bladder, and most cause of the cystitis is the urinary tract infection. The symptoms of cystitis are mostly is frequent urge to urinate, urge to urinate after you have empty your bladder, cloudy, strong smelling urine, low fever if the combination with urinary tract infection, blood in the urine, or pain during sexual intercourse, sensation of pressure, or the bladder fullness. Mostly it's caused by the urinary tract infection. Taking certain drugs like chemotherapy drugs, exposure to the radiation, if patient have the pelvic mass radiotherapy, or ongoing use of the catheter, irritating hygiene products. The types of cystitis, can be either acute or interstitial. In the acute cystitis, it is a case of cystitis that occurs suddenly, and interstitial cystitis is a chronic or long-term case of cystitis that affect the multiple layer of the bladder tissue. Other is the bacterial cystitis, drug-induced cystitis, radiation cystitis, foreign body cystitis, or the chemical cystitis. The etiology, the most common etiology is the E. coli in uncomplicated UTI in the women, and approximately 75 to 95% cases. Other common etiology pathogens include the species of the Enterobacter family, such as the Proteus mirabilis, Klebsiella pneumoniae. Relation of the cystitis, it is diagnosed by the urine analysis in pyuria, depistage test for leukocytosis, trace or nitrate, urine culture, pregnancy test in the woman, childbearing age, the patient who have complicated cystitis who do not respond after the 48 to 72 hours of appropriate antimicrobial treatment will require further evaluation through the radiographic imaging of the upper urinary tract or CT scan. The treatment of the uncomplicated cystitis, we use trimethoprim sulfamethoxazole double strand 160 by 800 mg per oral BID for 3 days. Fluoroquinolone, ciprofloxacin, levofloxacin, and ofloxacin. The dosage of ciprofloxacin is 250 mg per oral twice a day for 3 days, or levofloxacin 250 to 500 mg only for the 3 days, and ofloxacin is 300 mg BD for 7 days. The alternative is nitrofurantoin monohydrate or the macro crystals 100 mg per oral BID for the 5 days, and the phosphomycin sachet 3 gram single dose. The bladder pain syndrome. It is a syndrome of the mystery in the urology. And the AUA guideline defined the interstitial cystitis and the bladder pain syndrome. It is unpleasant sensation, pain, pressure, or discomfort perceived to be related to the urinary bladder associated with lower urinary tract symptoms, more than 6 weeks duration in the absence of infection or other identifiable cause. The etiology of the bladder pain syndrome or interstitial cystitis are the multifactorial etiology, defective the bladder epithelium, mast cell activation may cause a neurogenic inflammation or C fiber activation. In the bladder insult, the epithelial layer damage and then develop the potassium leakage into the interstitium, and then activate the C fiber and release substance P, which activate the mast cell and histamine release, more injury. Same in the there is the bladder in the bladder there is the normal protective bladder lining, which is thinning, and then pinpoint bleeding accumulation on the bladder wall may lead to Horner's lesion in the bladder wall. The sign and symptoms of the bladder pain syndrome: pain in the suprapubic or the pelvic, dysuria, persistent to urge to urinate, frequency and nocturia. The frequency is more than 12 times per day, and the nocturia is more than 10 times. So, dysphagia and the chronic pelvic pain. Evaluation diagnosis of the depend upon the exclusion criteria and the cystoscopy criteria. The chronic history of the unexplained bladder irritability and suprapubic pain, frequency volume chart, and negative urine analysis and culture. In the cystoscopic finding, there is a redent mucosal area often associated with small vessel radiating toward the central scar, sometimes covered by the small clot or fibrin deposit. Horner's lesion, it is about 10% patients have the Horner's lesion. And other the scar rupture with the increased bladder distension, producing the characteristic waterfall hemorrhage. And hydrodistension, the granulation after the low pressure hydrodistension, consider a positive diagnostic sign. More than 10 granulation per quadrant in 3 out of 4 quadrants. The National Institute of the Diabetic and the Digestive and Kidney Disease criteria, the including criteria, the Horner's lesion, granulation on the scopy, pain on bladder filling or relieved by empty, pain in the suprapubic pelvic urethra, and the decrease the bladder compliance on the cystomatogram. Need 2 positive symptoms to confirm. The exclusion criteria: the age younger than 18 years, or the bladder tumor, tuberculosis cystitis, bacterial cystitis, radiation cystitis, the active genital herpes, bladder ureteric alkali, and the frequency less than 5 times in 12 hours, or absence of nocturia, symptoms relieved by antibiotic, or the bladder capacity more than 350. The treatment of the interstitial cystitis or bladder pain syndrome. The clinical guideline AUA create a flowchart of the suggested order of the treatment. First line through the 6th line as needed. The conservative treatment first and avoid surgery if possible. The exception is fulguration of Horner's lesion must be done first. Multiple simultaneous treatment often best. The pain management should be priority. The first line treatment, educate the patient about the interstitial cystitis and the behavioral modification, timely white, control fluid intake, the stress reduction, avoid of the triggers, dietary changes, avoid the acidic foods, coffee, tea, soda, spicy food, and the alcohol. Second line treatment, oral treatment, amitriptyline, cimetidine that inhibit the histamine receptor to decrease the pain signal transmission. And the pentazone on the almiron, which repair the damage of glycosamine glycan layer of the bladder mucosa, and is only FDA approved. Take 3 to 6 months to see the effect, and the only effect the approximately 25% of patients. It creates a barrier on the bladder wall to prevent the irritation, and its dosage is 100 mg capsule for 3 months, and total dosage thrice a day, 300 mg per day. In an intravesical treatment, dimethyl sulfoxide is only FDA approved anti-inflammatory and analgesic and muscle relaxant. We use a heparin, which is function as the glycosamine glycan layer for the bladder, and also use a lidocaine plus corticosteroid. The third line treatment is hydrodistension. The cystoscopy, short duration, low pressure, the hydrodistension most common treatment, 50% efficacy, and effect lasts about 6 months. Inflate the bladder with saline at the 80 centimeter of pressure is 80 centimeter of water, and 800 to 1 liter volume. Maintain pressure for a few minutes, then drain bladder. Fourth line treatment is the neuromodulation, in which sacral nerve stimulation involved implanting the permanent electrodes to stimulate the S3, S4 roots, approved for the rectal overactivity in 1997 and for the urinary urgency and frequency in 1999. And the early studies suggest that about half of the patient with the prostatic pain bladder syndrome may be derived benefit from the neuromodulation. The fifth line treatment is the cyclosporin A, which is anti-inflammatory or immunosuppressive, more for the patient with the Hunner's lesion, and so effective is versus 85% to 30%. And the other one is the intradetrosal Botox injection. The risk of the requiring intermittent catheterization after the treatment, and up to the 4 injection separated by the 6-month effective for the symptoms and the pain relief, as well as the increasing the bladder capacity. Not as effective for the patient with Hunner's lesion. And last one, 6th line treatment is surgery, cystoplasty, part are all bladder removed and replaced by the section of the bowel to function as a new bladder, augmentation cystoplasty. And it is uncommon in urinary diversion with or without cystectomy. And the last one is chronic pelvic pain syndrome. Chronic pelvic pain syndrome, previously known as the chronic non-bacterial prostatitis, is a condition with long-term pelvic pain without evidence of the bacterial infection. The presentation, the clinical features are more than 3 months of localized pelvic pain, perineum, suprapubic or external genitalia, lower back, pain with circulation, lower unit symptoms, dysuria, frequency, urgency, poor flow may associate with erectile dysfunction. The symptoms can be difficult to treat. The evaluation of the chronic pelvic pain syndrome with the detailed history, including the inquiry associated with disorder of the psychological assessment, the National Institute of Health Chronic Prostatitis Symptom Index. The score have 3 main symptoms. The first one is pain, location, and the frequency and severity, widening obstructive or irritative symptoms, and impact on the quality of life. urinofilmetry, post-wise residual volume, and the segmented urine culture. Semen analysis in the culture, urethral swab for the culture to exclude the sexual transmitted infection. Urine cytology, if suspicious of any bladder malignancy. Urodynamic study to investigate the voiding dysfunction. Cystoscopy, if suspicious of any urethral stricture, bladder outlet obstruction, or the bladder pathology. And the transrectal ultrasound PSA. The treatment of the chronic pelvic pain syndrome, mostly it's a conservative therapy, counseling, education, and the anxiety or reduce the stress, psychotherapy, focus the pelvic physiotherapy for the tenderness of skeletal muscle, gentle exercise, avoid aggravating factors. We can give the alpha blockers, antibiotics, sometime benefit in patient with early or newly diagnosed of the inflammatory chronic pelvic pain syndrome, ciprofloxacin, levofloxacin for the 4 to 6 weeks, and anti-inflammatory drugs and NSAIDs and for alpha reductase. The analgesia with the specialist pain team input, the muscle relaxant diazepam use, the prostatic massage 2 to 3 times per week for the 6 week with antibiotic, local heat therapy. If no pathology identified, there is no response to the initial treatment, then refer to the chronic pain team. Thank you.